So we have multiple drugs. We have multiple abnormalities. They sort of fit with each other. Some of them address multiple defects. So maybe I'll turn back to you, John. What do you think would be the best option for this case, who may or may not have cardiovascular disease? She's reluctant to accept a diagnosis of diabetes. Or would you push for her to have an injectable, or she doesn't have heart failure right now, but would that help in your choice of therapy?
Yeah, I think it would. I mean, I think if she had definite heart failure, the SGLT2 class, at least two agents, canagliflozin and empagliflozin, have been shown to reduce admissions for heart failure. I think the other thing about this woman is just getting her to buy into the fact that she really does have a disease that needs to be treated, and that diet and lifestyle are important, but she's at the point at 8.4% where she definitely needs medical therapy. The other thing is, if this were a new patient, one of the main things that we do in terms of diagnosing cardiovascular disease is to have a talk with the patient. Let's have a conversation about this chest pain and what got you a nitroglycerin PRN prescription. Because if there's any clinical indication this patient's having some symptoms, we need to know that, and we need to diagnose it, because it might influence our decision making. But this woman at 8.4%, you and I would talk and have a conversation. What is she willing to do? But certainly you might talk about metformin in this patient. And then the question is, would you go with one agent, see her back in 3 months and see how she's done? Or would you say she's at 8.4%, perhaps we think about dual therapy? And there's a lot of different ways, as you outlined, to sort of skin that cat between oral agents and injectables. So again, lots going to be upon what she's willing to do and how much of a buy-in she's willing to put to this.
Right. I agree with you. We need to share the decision-making process with the patient.